always a physiological sign, not a primary cardiac disease. It is the heart responding to a systemic demand. Severe pain, a massive hemorrhage, high fever, sepsis, or a pulmonary embolism.
So you don't treat the heart.
Exactly. You do not treat the rhythm directly with cardiac drugs. You must hunt down and treat the underlying cause.
Okay, the second suspect in the narrow regular box is SVT supraventricular tachycardia, specifically AVNRT.
Right.
This presents as an abrupt, sudden onset racing heart, often at rates between 150 and 250 beats per minute. The P waves are usually buried inside the fast QRS complexes or retrograde and hidden. The fundamental mechanism here is described as a circus movement.
The circus movement, yeah.
Can you explain the cellular mechanics of that circus for us?
It is a fascinating anatomical glitch. Inside, or just adjacent to the AV node, the patient possesses two parallel microscopic electrical pathways.
Two pathways.
Yes. One pathway conducts electricity very quickly but takes a long time to reset or repolarize. The other pathway conducts electricity slowly but resets very fast.
Okay, so fast, slow, and slow, fast.
Exactly. Usually this does not cause a problem. But if a premature, ill-timed ectopic beat comes down from the atria, it finds the fast pathway still resetting, so it gets blocked there.
It has to take the slow path.
It has no choice. By the time it finally reaches the bottom of the slow pathway, the fast pathway has finished resetting. So instead of just continuing down to the ventricles, the electrical impulse also turns around and travels backward, up the fast pathway.
It goes up the down escalator.
It creates a closed, continuous loop. The electricity literally chases its own tail in a rapid circle inside the AV node, and every single time that electrical wave completes a lap around the loop, it triggers a ventricular heartbeat. That circular trap is the circus movement.
That is a phenomenal explanation. It explains why it starts and stops so abruptly. It is literally a light switch being flipped on.
It is.
Okay, the third suspect in the narrow regular box is atrial flutter. This is where the atria are firing furiously at around 300 beats a minute, creating a continuous sawtooth pattern on the baseline.
A very distinct sawtooth.
But why doesn't the ventricle also beat at 300?
Because of the AV node bouncer. The AV node simply cannot conduct impulses that fast. It physically protects the ventricles.
No, filters them.
Yes. In atrial flutter, the AV node typically blocks exactly every other beat. It only lets 1 out of every 2 atrial impulses through to the ventricles. So an atrial rate of 300 divided by 2 gives you a ventricular rate of almost exactly 150 beats per minute.
Yes, the 150 reflex. If you are ever looking at a perfectly regular, narrow, complex tachycardia humming along at exactly 150 beats per minute, your brain should immediately suspect atrial flutter with 2.1 conduction block until proven otherwise.
It is a classic presentation.
Let us slide over to box 2, narrow and irregular.
The absolute king of this box is atrial fibrillation.
The famous AFib.
The atria are not contracting uniformly. They're just quivering chaotically, generating hundreds of disorganized microsignals. There are no distinct uniform P waves to be found, just a messy fibrillatory baseline.
And the ventricles.
Because the AV node is being bombarded randomly, it lets impulses through at completely random intervals. The resulting QRS complexes march out irregular.
Now we move to the lower half of the matrix where the stakes get incredibly high. Box 3, wide and regular.
Wide and regular.
The QRS is fat greater than 0.12 seconds, meaning the impulse is outside the superhighway and the beats are marching out perfectly.
This brings us to a diagnostic rule that unequivocally saves lives. If you see a wide, regular tachycardia on the monitor, you must presume it is ventricular tachycardia, or VT, and treat it as such until definitively proven otherwise.
Why are we so aggressive with that assumption?
Statistically speaking, upwards of 80% of these rhythms are VT anyway, particularly if the patient is older or has any history of structural heart disease or prior myocardial infarction. The rhythm is originating deep within the ventricular muscle, spreading slowly cell by cell, hence the wide QRS.
Let me play devil's advocate, though. I have seen cases of SVT, a supraventricular rhythm from the top of the heart, where the patient just happened to have a pre-existing bundle branch block.
It does happen.
That makes their QRS wide too. So it's just a benign SVT with aberrancy. Couldn't box 3 just be that?
It absolutely could be SVT with aberrancy. But here is the critical, unforgiving danger of making that assumption. If you assume the rhythm is a benign SVT, your standard treatment would be to push a calcium channel blocker like verapamil or diltiazem to slow down the AV node.
And if you're right, it works.
If you are right, the SVT breaks. But if you are wrong, if that wide rhythm was actually ventricular, Tachycardia, giving an AV nodal blocking drug with negative inotropic effects, will cause catastrophic cardiovascular collapse. You will instantly drop their blood pressure to 0 and potentially kill the patient.
So what happens if we treat it like VT instead?
If you presume it is VT and you treat it with safe ventricular antiarrhythmics like amiodarone or with synchronized electrical cardioversion, the patient survives regardless of whether it was actually VT or SVT with aberrancy.
Electricity is safe for both.
Exactly. Electricity is safe for both. Verapamil is deadly for VT. Therefore, the rule remains absolute. Treat all wide regular tachycardias as ventricular tachycardia.
Such a powerful clinical pearl. Box 4 is the final quadrant, wide and irregular.
This is pure electrical chaos. This is polymorphic VT or torsades de pointe, which we discussed with the prolonged QT interval.
The twisting rhythm.
Yes. The axis of the wide QRS complexes appears to twist continuously around the baseline. We treat this aggressively by pushing intravenous magnesium sulfate to stabilize the cardiac membrane, and we prepare for immediate defibrillation because it frequently decays into ventricular fibrillation.
All right, bringing this back to our 24-year-old woman in the casualty ward. She is totally stable. We apply the matrix. Her rhythm is narrow, so we are in the top half.
And it is perfectly regular at 186 beats per minute. No visible P waves.
She is firmly in box 1. We diagnose SVT, specifically AV-NRT. We need to stop that circular circus movement you described. How do we break the loop?
We begin non-pharmacologically. We use vagal maneuvers to stimulate the vagus nerve, which naturally dumps acetylcholine onto the AV node to slow it down.
Like coughing or bearing down.
Exactly. We might have her blow forcefully into a modified syringe or bear down as if having a bowel movement. If those maneuvers fail to break the circuit, we escalate to a pharmacological intervention. We push a drug called adenosine intravenously as a rapid bolus.
Adenosine, what does that do?
Adenosine essentially acts like a hard reset button for the AV node. It causes profound hyperpolarization of the nodal cells, pushing potassium out, and briefly stops all electrical conduction through the node. It creates a complete momentary roadblock.
The clinical literature frequently notes that this experience is highly distressing for the patient.
You must warn them beforehand, because adenosine completely blocks the AV node. For about 3 to 6 seconds, their heart will literally pause.
They flatline for a few seconds.
Yes. They will stare at you, and they will feel a profound, terrifying sense of impending doom or chest tightness. But because the drug's half-life is incredibly short, less than 10 seconds, it washes out quickly.
And then the heart restarts.
The circular circus loop is broken by the pause, the natural sinus node assumes command once again, and the crisis is instantly resolved. No electrical shock is required.
Brilliant. All right, let's take another pause here and transition to part 4. Welcome to part 4. Bradycardias and AV blocks. We have thoroughly explored hearts that race out of control. Now we must examine hearts that forget to hurry. The slow rhythms.
When presented with a significantly slow heart rate, the overriding clinical question, much like question 0 for tachycardias, is whether the bradycardia is actually causing hemodynamic symptoms.
Right. Is it causing a problem?
Exactly. Is the slow rate causing the patient to faint, experience profound confusion, or suffer from severe hypotension? An asymptomatic slow heart in a sleeping patient or a highly trained athlete is usually just an observation.
But if they are dizzy and pale...
A symptomatic failing slow heart requires immediate diagnostic action.
But to take the correct action, we need to understand the fundamental mechanics of why the heart is slow. It usually involves a block in conduction.
Yes, a block.
But not all blocks are created equal. We need to explore the golden concept of level. Why are some slow hearts considered a benign nuisance, while others are ticking time bombs waiting to arrest?
It entirely depends on the anatomical level where the electrical signal is being obstructed. We categorize these blocks into 2 distinct physiological levels, nodal and infranodal.
Let's define nodal first.
Nodal blocks happen high up in the conduction system, right within the body of the atrioventricular, or AV node itself. This specific area is richly supplied by the autonomic nervous system, heavily innervated by the vagus nerve.
So it's very responsive to the body's signals.
Yes. Blocks here are often reversible. They respond to fluctuations in vagal tone, medications, or metabolic changes.
And infranodal.
Infranodal blocks happen lower down, below the node, in the His bundle, or the branching Purkinje fibers. This lower area does not possess that rich autonomic nerve supply.
So they don't respond to vagal changes.
No. Therefore, conduction blocks here are almost always caused by irreversible physical damage. calcific fibrosis, structural disease, or massive necrosis from an anterior myocardial infarction, destroying the tissue.
I want to share an analogy that perfectly clarifies this distinction for our listeners.
Please do.
A nodal block is like a polite, physically exhausted runner. They start to fatigue, they slow down gradually, they give you plenty of warning signs that they're struggling, and eventually they need to stop and rest.
That's very true.
But if you give them a chemical stimulant, like the anticholinergic drug atropine, which blocks the vagus nerve, they perk right back up and start running again.
Because the tissue is still alive.
Exactly. But an infranodal block, that is not fatigue. That is a concrete bridge that has sustained catastrophic structural damage. It does not warn you. The cars are driving across it perfectly fine, and then suddenly, without a single warning sign, the bridge violently collapses.
And atropine won't fix a bridge.
Crucially, no amount of atropine or stimulants is going to rebuild a collapsed concrete bridge. You need a mechanical, permanent fix.
That analogy maps perfectly onto the specific degrees of AV block we identify on the electrocardiogram. Let us walk through them, starting with first-degree AV block.
That is the simplest one. The PR interval is prolonged, permanently stretching past those 5 small boxes greater than 0.20 seconds. But every single P wave successfully results in a QRS complex.
The signal is delayed, but it is never completely dropped.
Right.
It is almost always a high-level nodal block, the tired runner just taking a bit longer to pass the baton. It is clinically benign and requires no specific treatment unless it presents as a brand new acute finding during a myocardial infarction.
Then we progress to second-degree block, which is where things get interesting because it presents in 2 very distinct, physiologically opposite flavors.
Flavor number 1 is Mobitz type I, universally known as the Wenckebach phenomenon.
Wenckebach, the polite runner.
Wenckebach is the ultimate polite runner. When you observe the ECG, you watch the PR interval physically stretch. It gets longer and longer and longer with each successive beat.
You can see the fatigue happening.
The AV node is fatiguing. Finally, the node is so exhausted that one P wave is completely blocked, and it is not followed by a QRS. A beat is dropped.
But then it rests.
Exactly. That brief pause allows the AV node to rest and fully recover. The next PR interval starts out short again, and the fatiguing cycle resets.
Because it drops a beat in a rhythmic, predictable cycle, it creates a visual pattern on the paper called grouped beating clusters of QRS complexes, separated by pauses.
You can often spot Wenckebach from across the room. It warns you before it fails. Because it is a nodal block, if the patient does become symptomatic, pushing atropine works beautifully to resolve it.
But the other flavor of second-degree block, Mobitz type 2. This one is the silent assassin.
Mobitz-Neseck is the infranodal block, the structurally damaged bridge. If you look at the ECG, the PR interval is perfectly constant. It does not stretch. It does not warn you of impending fatigue.
So it looks totally fine until it doesn't.
Every beat looks stable, and then suddenly, without a single millimeter of warning, an electrical beat just vanishes into the void. You see a lonely P wave completely disconnected with no subsequent QRS.
The clinical danger here is astronomically high, isn't it?
Very high. Because this block is caused by permanently damaged necrotic tissue below the AV node, that remaining pathway can decay into a complete fatal heart block or ventricular standstill at any unpredictable second.
And atropine.
Atropine is completely useless here. It will not repair dead tissue. A patient with Mobitz-Neseck requires temporary pacing pads placed on their chest immediately, and ultimately they will require the surgical implantation of a permanent pacemaker.
What about third degree or complete heart block?
That is the ultimate failure of conduction. The atria and the ventricles are completely electrically divorced. The SA node is firing the top of the heart at a normal rate, and the ventricles, realizing no signal is arriving, are firing on their own intrinsic, desperate escape rhythm at a much slower rate.
How slow?
Perhaps 30 or 40 beats a minute. The P waves and the QRS complexes march through the tracing completely independently with zero communication or predictable relationship. Like Mobitz 2, symptomatic third-degree block requires definitive pacing.
Now there is a highly tricky diagnostic puzzle we must discuss. The 2.1 block imposter. What happens if the ratio is exactly 2-to-1, meaning every other P wave is dropped?
It creates a fascinating diagnostic dilemma. If you have 2 P waves for every 1 QRS complex, you literally never have 2 consecutive PR intervals to compare against each other.
I see. You can't tell if it's stretching.
Exactly. Therefore, you cannot tell if the PR interval was trying to stretch like Wenckebach or if it was remaining constant like Mobitz 2. You simply cannot name the block based on the PR intervals alone.
So how do you figure out the level? How do you know if you are looking at the tired runner who might respond to atropine, or the collapsing bridge that needs a pacemaker right now?
You have to look for secondary clues elsewhere on the tracing. First, scrutinize the QRS width.
The widths.
If the QRS complex is narrow, it proves that when the impulse does get through, it is successfully utilizing the intact His-Purkinje superhighway. That strongly implies the block must be higher up in the AV node itself. It is highly likely a nodal Venka-Bach variant.
And if the QRS is wide?
If the QRS complex is wide, it suggests the His-Purkinje highway is structurally damaged. That implies the block is likely lower down, infranodal, behaving like a dangerous Mobitz 2.
Can you test it with drugs?
You can perform a diagnostic challenge.
That completes parts 3 and 4. The finale, STEMI and the deadly patterns, is next.